All right, we're continuing with chapter 26, soft tissue injuries. We've already gone through the transport decision, so now on to history taking. Um, Even though our patient may be more obviously a trauma patient, we still want to rule out any medical complaints. A lot of our patients are going to have medical conditions on top of soft tissue injuries, either a chronic condition or something that has developed because of this trauma. So we don't want to just rule that out. We definitely want to use our OPQRST and sample, especially if we have more of like an isolated extremity injury, figure out what happened. Um, any information that you gather should be prioritized in case your patient goes unconscious. You want to get what you can. If the patient is unresponsive or goes unresponsive quickly, get as much information as you can and then roll out because we're not waiting unseen. Chronic conditions that we really need to pay attention to are like anemia or hemophilia, those things that can complicate bleeding wounds, essentially. For the secondary assessment, this is kind of the in-depth look. We've already done a quick head-to-toe assessment, trying to find those life threats. And now we want to look deeper, see if there's things that we missed. During that 90-second head to toe, we really weren't worried about injuries that weren't going to kill the patient. Now, hey, let's take a look at them. Let's bandage, let's do extra splinting, etc., to try and help the patient feel as comfortable as possible. The other thing that we really want to focus on with our secondary assessment is listening to breath sounds, kind of some of the stuff that we didn't do in that 90 seconds, really focusing on the patient's respiratory rate, looking for symmetrical chest wall movement, assessing neurologic signs, the pupil size and reactivity, motor response, sensory response, looking at the whole musculoskeletal system for DCAT BTLS, looking for signs of like pelvic instability, abdominal injury. If an abdomen is not soft, non-tender, it's very possible that something's going on in there. And then reassessing vital signs. We should have already taken a baseline set on a trauma patient. That's really important because they can change very, very quickly. But we want to look particularly at any signs that could say, hey, we have hypoperfusion going on here. So tachycardia, tachypnea, low blood pressure, weak pulse, and then of course that first sign is pale, cool, clammy skin. And then continuing to reassess. If your patient isn't like legitimately stable and you feel just perfectly fine, the more often you take vitals, the better picture you'll have for yourself and the less chance that you're going to miss something. Keep in mind though, just putting your monitor on auto to go off every 5 minutes doesn't do any good if you don't actually look at the reading. So while that is a very nice feature, you have to make sure to look at the number. So for your reassessment, you start at your primary assessment, look at all of the treatments that you have provided for the patient, seeing if that made any changes for that patient. Is there anything more that you can do? Reassess your vital signs, treat those secondary conditions, reassess the effectiveness of your bandaging is a big one. And then communicate and document everything that went on. You want to do with a description of the MOI. If it's an automobile accident, describe the vehicle that the patient was in. What kind of condition is that vehicle? You kind of are the person that is the eyes for the hospital. So paint the picture for them. Let them know how you found the patient, what the vehicle looks like, because they're not going to have the opportunity to actually look at the vehicle to just determine or look at MOI type injury patterns for themselves. So they're relying on you completely. So paint the picture. You want to describe the position in which you found the patient Any amount of blood loss that can be seen at the scene. Again, not necessarily saying they lost 500 mils, but they had blood that soaked here, 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 and here. It had coagulated here. It had pooled here. It was approximately this size. That's going to be much more helpful. You want to look at describing any of the soft tissue injuries, any other wounds, if they have depths that you can adequately and accurately describe, and then what you particularly did for each of those injuries. Emergency medical care for closed injuries, really small contusions, not going to require anything. More extensive closed injuries can have pretty significant bleeding, which can lead to hypovolemic shock. The biggest thing is, can you recognize it? When you first roll up, there may not be anything because it takes time for blood to collect and it might not be there. So we have to continue to reassess to make sure that now all of a sudden they aren't swelling, that they don't have low blood pressure, that all of a sudden they went from warm, pink, and dry to pale, cool, clammy. We don't want to wait to the point where they're definitely not able to compensate anymore before we catch it. And this will come with experience, that spidey sense of, yeah, something's not right here. You will develop that at some point. For most of our closed soft tissue injuries, we're going to use the Rice's mnemonic. So this is rest, ice, compression, elevation, and then splinting to provide support. Most of our closed injuries are not going to be super severe, needing a lot of care. A lot of them are going to be pretty mild, but we do need to keep an eye out for developing shocks. So changes in mental status, tachycardia, tachypnea, starting to get pale, cool, and clammy. And then, of course, the ever telltale sign of, yeah, your blood pressure is actually going down now. If any patient starts exhibiting any of these signs of shock, we're going to go ahead and treat them quickly. We don't want to let them, wait it out and see how it goes. For open injuries, first and foremost, follow standard precautions. Take care of yourself and your partner first. If the bleeding that you see is life-threatening, start with direct pressure first and foremost. If that wound is in the chest, upper abdomen, upper back, neck, etc., we're going to put an occlusive dressing. Remember, occlusive dressing is that which air cannot penetrate. When we go to controlling bleeding, direct pressure is going to be the best to begin with, at least. The next, you can try elevation. That's really not something that is super in favor anymore, but it's worth a shot. Pressured dressings or splints, and then tourniquets. Tourniquets are a lot more in favor than they used to be. All wounds that are open are just going to be assumed to be contaminated. You can apply a sterile dressing to decrease the likelihood of further contamination, but it's already contaminated. It's dirty. We don't do any cleaning or removing of materials in the field. If it's a small wound without significant bleeding, we can flush it if you want to, but again, that's just best left for the hospital. They don't even do that first and foremost. They're going to take care of issues and they'll actually debride the wounds well after time. So, not too worried about it. You can control bleeding in an extremity by splinting it, even if there is no fracture in it. So keep that in mind. Reducing that movement and whatnot, very helpful. For abdominal wounds, you can have some pretty gruesome wounds, as you can see here on the screen. Any sort of injury to the abdominal cavity does have the potential of exposing internal organs. What you're seeing on the screen is called an evisceration. That's when any of those organs actually protrude through the wound and out of the abdominal cavity itself. So how do we fix this? First and foremost, don't put them back in. We don't want to put them back in. So we're going to cover the wound with sterile gauze, kind of moistened with some saline. Secure the gauze with an occlusive dressing and try and keep the organs moist and warm. Most patients are going to need to go to surgery right away, so we don't want to delay any of that transport. For impaled objects, occasionally we're going to have patients that have things sticking out of their body that should not be there. First and foremost, leave it in place. Unless it obstructs the airway, like the cheek, the mouth, or if it's in the chest and interferes with CPR. Those are the two circumstances on which that we're going to actually take it out. If the object is super long, try securing it first and then shortening it down. And then obviously rapid transport. Open wounds to the neck can be life-threatening. Not only do you have veins of that neck, which may suck in air and end up leading to an air embolus, causing cardiac arrest, but you also have airway there as well. So you have a couple of different major systems coming into play. So we want to cover the wound with an occlusive dressing. We want to keep the air that's outside from getting in, but we also want to keep the air that's in the airway from leaking out somewhere else. We can still apply manual pressure, but we're not compressing both sides of the neck at the same time. That's why we don't like to wrap anything directly around the neck. You typically go around the side of the neck, down under the arm, back up, around the neck, down under the opposite arm, so that you're not going directly around the neck. We don't want to occlude both of those carotid arteries at the same time. Keep in mind, though, if you have an injury to that neck, a wound, etc., you may have C-spine that needs to be controlled as well. For bites, small animal bites don't look super terrible, but little animals are severely infected with bacteria in their mouth. And it's good for them. It helps them eat their food. It's natural. We all have a flora that we should have, and unfortunately these small animals have them. So we want to consider all small animal bites to be contaminated and could potentially become very, very infected. So treatment is probably going to require debridement or removal of damaged tissue, antibiotics. They're probably going to get a tetanus shot just in case, and then you may need to have surgical repair. We want to go ahead and have all small animal bites evaluated by a physician, no matter how mild they may seem, whether we take them in via ambulance or we have them go to their primary care. One thing that we do want to worry about is the spread of rabies. That's a potentially fatal viral infection of the central nervous system, and it affects warm-blooded animals. So the virus is going to be in the saliva of that rabid or infected animal, transmitted through biting or licking an open wound. And the infection itself can only be prevented by a series of special vaccine injections. The animal may end up turning and attacking us as well, so we want to try to make the scene safe by containing whatever animal it was that did the biting. And we don't take chances. If it already attacked one person, we don't need to become a second victim by any means. So we'll go ahead and call it right here, and I will continue on in the next video.